for supervised exercise therapy. What does that actually mean for patients to be in a program like that?
Yeah, so this is a really remarkable addition to treating peripheral artery disease is that we have an intervention that's exercise-based, that's covered by insurance and recommended for anybody that has symptomatic claudication or peripheral artery disease. And so if you look back, the CLEVER trial was an NIH-sponsored trial where they randomized patients with symptomatic peripheral artery disease involving the iliofemoral system to, it was originally 3 arms. It was a medical therapy group, a stenting group, and then a exercise group. And then it became really, because of enrollment issues, 2 arms. It was medical therapy in the baseline of everyone, and they got randomized to either iliofemoral stent or a supervised exercise program. And what they found in that CLEVER trial was that you get similar impact on claudication onset time, how early did your symptoms start, as well as the degree of symptom pain between a stent and a exercise program. So, I mean, pretty slam dunk win for exercise program. And they did a 1.5 year out study, follow-up study, and there was persistent benefit. So exercise really came out of that as good as stents, which should be used before surgery or interventions recommended. So the exercise program itself is a graded treadmill program where they try to pretty much walk you, push you to your pain point, and then try to keep advancing you on that treadmill to get to the next level. And so it's done between 15, 30-minute intervals. So we actually have our physical therapists trained to do it. And a lot of people do it also through the cardiovascular rehab program. The problem with the supervised exercise therapy has just been really access and compliance. I think access has been a big issue. It's not a money-winning intervention, so it's hard to get centers to invest in it. And then also a lot of patients work or they can't go 3 times a week. And so a lot of people who do end up going are those that are retired and, they're looking for something to do.
What is happening to the body that pushing them to exercise, which they're like, what, that hurts. Why are you so counterintuitive? Actually helps them in the long run.
Yeah, there's a lot of theories behind that. That's a great, important question. I think of it as there's some degree of angiogenesis that can be prompted with advanced exercise like that. So really helping build an extensive network of collaterals for people who have more occlusive disease. And then there's also just the local effects of muscle strengthening, accessory muscles. And a lot of these patients are deconditioned and aren't very ambulatory at baseline. And so enriching the supportive environment can also help a lot with that pain response.